Thanks so much for the introduction and for the invitation to speak here. It's really a pleasure to speak to this group. I'm honored to be the international representative here, and I've been really quite impressed and inspired by what's going on here in Nebraska in terms of all of your collaboration and commitment to stewardship. So it's a real honor to be here. So this talk is about antibiotic use and resistance associated with the COVID-19 pandemic. And I know that, the WHO has said that COVID-19 is no longer a public health emergency, but it's still very much with us. And we also have to look forward in terms of future pandemics, as we know that that's going to be inevitable. And I think some of the learnings here will apply not only to future pandemics, but also antimicrobial stewardship in general. So our objectives today are to talk a little bit about one of the main reasons why antibiotics may be overused in patients with COVID-19 is the concern for bacterial co-infections and secondary infections. We'll talk a little bit about antibiotic prescribing in patients with COVID-19 and how the pandemic may have impacted prescribing practices. And then really what we're all trying to mitigate here is antimicrobial resistance. So what impact has COVID-19 had on AMR? There are really opposing factors that are working in both directions to both decrease and increase antimicrobial resistance, so we're not exactly sure how this is going to pan out. On the left-hand side, factors working in our favor, at least temporarily associated with a lot of the public health interventions during the early part of the pandemic, like physical distancing and hand hygiene. All of this had resulted in reduced respiratory tract infections and reduced antibiotic prescribing, at least in the community setting. But on the right-hand side, we have factors that are a little bit more concerning here related to high antibiotic use, particularly in patients with COVID-19, even though we know that the rates of co-infection are quite low. So I'll talk a bit about that later. And then to make matters worse, I'm sure many of you experienced this, is that antimicrobial stewardship programs and infection prevention and control programs were spread quite thin during the pandemic trying to respond to the COVID-19 emergency, and that may have let some of the antimicrobial resistance slip through the cracks. So we know from previous pandemics, like influenza, that there was a concern that a lot of the morbidity and mortality from these infections is actually related to secondary bacterial infections. So I think that was one of the main reasons why we saw a lot of antibiotic prescribing, especially early on in the pandemic. There's also, to add to that, the uncertainty when a patient presents to you with a respiratory tract infection. Does this patient have COVID-19 versus a bacterial pneumonia? So we'll talk a little bit more about the bacterial co-infections in patients with COVID-19, as this is a rapid review and meta-regression that we did early on in the pandemic to describe how often is it that these patients with COVID-19 actually have bacterial infections and necessitate antibiotic therapy. And so we included a lot of studies, 171 studies, over 171,000 patients, and we looked at whether the study classified the infection as a bacterial co-infection, so that occurring within 48 hours of presentation, versus a secondary infection, that occurring 48 hours or more, so we would consider a healthcare-associated infection. And for the most part, most of the patients that we see in the hospitalized setting have a fairly low rate of a bacterial co-infection at 4.4%. In the ICU, that is a little bit higher. But I think where the main concern around high co-infection rate is actually in hospitalized patients in the ICU who have stayed there for a long time. And this may be due to a number of factors, including invasive procedures, mechanical ventilation, intravascular devices, et cetera. So not so much related to the infection with COVID-19 itself, but the fact that you've been in the hospital receiving quite invasive procedures. What we found in our meta-regression was that there were some key predictors associated with having a bacterial co-infection. These are probably not surprising to you, that populations that had more patients who were mechanically ventilated were more likely to experience co-infection, and those who were in the ICU had a hugely increased odds of getting a bacterial co-infection as well. So this tells us a little bit about, where we should, and probably more importantly, where we should not be empirically prescribing antibiotics in patients who don't have clear evidence of a bacterial infection. So this leads us to the discussion about antibiotic use and overuse during the pandemic. This slide here is to showcase a few, this is not comprehensive, but a few of the key practice guidelines that comment on whether or not we should be using antibiotics in the absence of a bacterial infection. So, and I put mild, moderate, and severe here, with mild being outpatients, moderate being inpatients, non-ICU, and severe being ICU. And you can see that generally across the board, those patients with mild and moderate infections, there are no guidelines that recommend empiric or prophylactic antibiotic therapy in those patients. It's the severe patients where there's a bit of a mismatch or of different guidelines recommending different things. But actually, if you looked at this a few years ago, you'd see a lot more green check marks where there were recommendations to just, across the board give antibiotics to patients if they entered the ICU with severe COVID-19. So there's some movement in the right direction here, but I think the key point here is that most mild and moderate COVID-19 infections in the absence of clear signs and symptoms of bacterial infection should not be receiving antibiotics. So that's what the recommendations say, but what was actually happening in practice? This is another rapid review and meta-analysis that we did looking at the prevalence and the associated factors with antibiotic prescribing in patients with COVID-19. So we looked across all healthcare settings, all age groups, and then we pooled the results together using a random effects meta-analysis to get some estimates of the prevalence of prescribing. We included 154 studies with over 30,000 patients, and it was the first few months of the pandemic, and even during those months, lots and lots of studies. But you can see that represents, the first epicenters of the infection, so China, a few studies from the US, and a few studies from South Korea. So what we found is that antibiotic use far exceeds bacterial infection rates. About 3/4 of patients with COVID-19 received an antibiotic, but on the other hand, only 8.6% of patients actually had a bacterial co-infection. We're not actually commenting here, and we can't specifically say anything about appropriateness, but given that significant gap between the bacterial infection rate and the prescribing rate, that suggests that there's a high likelihood of unnecessary prescribing in these patients. We did see a lot of heterogeneity between studies, huge amount of variability, but if you look across region, there didn't seem to be one geographic region that was prescribing more than others. It was fairly high across the board, but we did see more prescribing in older age groups and more in mechanically ventilated patients. When you break down the population based on where the patient is, whether it's the ICU, the general hospital setting, or a mixed inpatient-outpatient setting, you can see that trend where more antibiotics are used in the ICU, to be expected. But even in these less severe populations, about 60% of patients were receiving antibiotics, which really suggests a high amount of unnecessary prescribing. We'd hope to see a trend towards reduced antibiotic use as the pandemic progressed. Not a statistically significant trend here, but visually you can kind of see that. But even by May of 2020, still around 70% of patients were receiving an antibiotic. In terms of the antibiotics that were used, it differed based on the region of the world. Fluoroquinolones were very commonly used in China, and then in North America, macrolides and beta-lactam, beta-lactamase inhibitors. So fairly broad spectrum agents, and many of these agents with greater concern for selective pressure, for antimicrobial resistance, and C. difficile infection. So there can be some detrimental outcomes associated with that. This is our visual abstract that helps to summarize the paper. This paper was published in CMI in 2021. So that kind of gives you a snapshot of antibiotic prescribing in patients with COVID-19 in the early period of the pandemic. But what about as we look forward? This is a summary, not to have to read through all of this, but just to get a sense of the directionality of the trend of antibiotic use in the hospitals during the pandemic. And you can see that for the most part, antibiotic use went up in many hospitals. There's a study by Valerie Vaughn and colleagues that indicated that many of those antibiotic choices were unnecessary, and even in patients who had proven SARS-CoV-2, patients continued to be on antibiotics for more than 5 days in many situations. I'll highlight one study from Ontario, which is where I work. This was a multi-center retrospective study where they looked at respiratory antibiotic use on medical wards and in the ICU during the different waves of the pandemic. So they did a time series analysis here, and this is looking at the general medicine wards. The ICU chart looks quite similar. You could see a spike in antibiotic use during the first wave of the pandemic, which then settles down for waves 2 and wave 3. And the authors of this paper felt that there were some key things that helped to reduce antibiotic prescribing and get it back to where kind of normal levels. And they felt that, they have them in the asterisks there, superimposed on the COVID-19 hospital admission rate, showing that the first asterisk is the release of regional guidelines that discouraged antibiotic prescribing in COVID-19 in the absence of bacterial infection. And then the second 2 asterisks was the publication of data that shows, from a systematic review, that shows relatively low co-infection rates in hospitalized patients with COVID-19. So they felt that dissemination of that data was quite helpful to support improved prescribing in those patients. How about in the community setting? It's a little bit of a different story there. With the exception of the dental practice, where there was quite a bit of antibiotic use increase, largely related to access issues and patients couldn't get surgery, so antibiotic use may have been inappropriately used in its lieu. We also saw in low and middle income countries a potential increase in antibiotic use. But across the board for high income countries in the US, UK, and Canada, for the most part, there was a decrease in antibiotic prescribing. I'll highlight a study here from Ontario again, using IQVIA data that's linked to outpatient visit data, so we can look at how these antibiotic prescribing has changed over time. And what we found was that there was a decrease in overall antibiotic prescribing as the pandemic emerged, with about 30% reduction in antibiotic prescribing. And this is the prescribing rates based on the different specialties. You can see family physicians, subspecialists, and other prescribers had a significant drop in prescribing as the pandemic happened, and the only exception is dentists. 31% reduction in antibiotic prescribing during the first year, and this was largely explained by decreased visits for respiratory tract infections. So not so much less prescribing per visit, but less patients being seen either virtually or in person for respiratory tract infections. This is another paper, again out of Ontario, that shows what some of those respiratory tract infections were that were most impacted. And they did this nice heat map with cluster analysis to show what the most highly impacted infections were. And so cluster 1 with all the red is the one that's decreased the most during the pandemic. And it's interesting to note what those infections were. And this is based on diagnostic billing codes: acute bronchitis, common cold, otitis media, pharyngitis, and sinusitis. The first 2 of these shouldn't really be receiving antibiotics in almost all cases. Otitis media, pharyngitis, and acute sinusitis, there are certainly cases where these patients will not require antibiotics. So I think the decrease in prescribing that we see may reflect a lot of reduction in unnecessary prescribing that wasn't even needed in the first place, and may help to serve as a potential target for what antibiotic use should look like in the community. What about going forward into 2022? This is data from Ontario looking at, we have a tool on our website that basically shows community antibiotic use stratified by different settings and by different classes of antibiotics. You can see that drop in usage during 2020 and 2021, but as respiratory tract infections came back, so did antibiotic prescribing. And that was driven largely by the green line there, which is penicillin without beta-lactamase inhibitors, and macrolide use. So those are kind of making a comeback as the pandemic had progressed. How about patients specifically with COVID-19 who are living or residing in the community? How did antibiotic use look like in those patients? So to answer that question, we did a population-wide retrospective study to evaluate the timing and the risk factors for antibiotic prescribing in these patients. And we included anybody in a nursing home or community dwelling adults over the age of 66 because we have universal health care coverage for drugs for over 65, so that's why we used that age group. And we looked at the first 2 years of the pandemic. Anybody with a PCR-confirmed SARS-CoV-2 diagnosis was included. So we looked at the pre-diagnosis period, 7 days before diagnosis, and then 7 days after, and the peri-diagnosis with both period combined. And we compared that to a control period for the same patient, so looking back 4 to 8 weeks before the diagnosis and comparing the antibiotic prescribing between those two periods. And that helps to reduce any risk of confounding because you're actually looking at the same patient with the same risk factors generally over time. So some of the predictors we were interested in looking at were sociodemographic factors, clinical, and whether or not they had received a COVID-19 vaccine series. And we defined that as receiving 2 or more doses of the COVID-19 vaccine. We included 13,000 nursing home residents and almost 51,000 community residents. In terms of antibiotic prescribing, considering the rates of co-infection should be very close to 0% in these patients, antibiotic prescribing is pretty significant in my mind. 22% of nursing home patients received an antibiotic and 13% in the community received an antibiotic. This is the table that looks at the incidence rate ratios of antibiotic prescribing compared to the control period, which is on the far right. You can see that overall at the top, 15 per 1,000 patient days pre-diagnosis, and actually higher post-diagnosis, 21 per 1,000 patient days in the nursing home patients. This means that even after people knew that the patient had SARS-CoV-2, they still had prescribed an antibiotic. So maybe this is where the concern for co-infection comes in. Further down in the chart is COVID-19 vaccine use. You can see that separation in terms of whether patients received 2 or more doses or not, and there was really a reduction in antibiotic prescribing in those patients who received 2 or more doses. Similar story in the community dwelling adults. Again, higher use in both pre and post-diagnosis period, and mitigation of antibiotic prescribing in those who had received vaccination. This is the incidence rate ratio for comparison, so you can actually get a sense of how much antibiotic use was decreased. And this is a multivariable regression analysis, so these are adjusted IRRs. You can see a 0.66, so basically a 34% reduction of antibiotic prescribing if you had received 2 or more doses in a nursing home. In the community, almost a 70% reduction in antibiotic prescribing if you have received vaccination. So fairly significant reduction in antibiotic use associated with this intervention, which may be related to reduced severity of infection. Here's the chart that basically shows the IRR over time, and you can see that spike around day 0 when patients were diagnosed. The blue line represents those who were not vaccinated, and the red line represents those who were vaccinated, and you can appreciate the mitigation effect of vaccination. So this leads us to our kind of final question of with all of this antibiotic use, what kind of impact might this have had on antibiotic resistance? This is another systematic review. You can tell I like doing systematic reviews. This was one where we looked at patients with COVID-19 in collaboration with the World Health Organization. We looked at patients with COVID-19 to see not only how often is it that they have a bacterial co-infection or secondary infection, but if they did, how often were those infections antimicrobial resistant? One of the challenges was that many studies don't fully report on antimicrobial resistance. So often they'll say, in passing, this was the rate of MRSA, this was the rate of VRE, but they won't do a fulsome assessment of susceptibility or resistance for those organisms. So only in 28% of studies was AMR reported for 4 or more species, and that was what we felt to be comprehensive. But in those studies that did report on AMR, it was quite high. So Acinetobacter species, almost 96% were carbapenem resistant. Klebsiella species, almost 70%. And then MRSA, about 41%. Some of the predictors that we saw for having an antimicrobial resistance were living in a low and middle income country, being in the ICU setting, and interestingly, diabetes and IL-6 inhibitor use were also associated with antimicrobial resistance. It's a bit of a snapshot in time about whether these patients had AMR, but it doesn't tell you very much about whether the pandemic was the cause of this. It could really just be reflecting the underlying population in which these patients were studied. So the question still remains is what was the impact of the pandemic on antimicrobial resistance over time? And that was the question for our next systematic or rapid review. What is the impact of COVID-19 on AMR at the population level? And this is where we searched WHO's COVID-19 research database for published literature using the terminology bacterial infection, searching up to June of 2022. And we included any study that reported on antimicrobial resistance before versus during the pandemic, or any study that looked at AMR as an association with the volume of COVID-19 cases at a particular time. The outcomes that we were interested in were the rate ratio or the risk ratio of antimicrobial resistance, and we pooled these results across gram-positive and gram-negative organisms, and then stratified by whether that study had reported having an enhanced infection prevention and control or antimicrobial stewardship program. And the reason we did that is because many studies will report on AMR as kind of an observational approach. Let's watch and wait and see what kind of impact the pandemic might have had on AMR, versus others framing it as we're actually intervening here by improving certain IPAC-related practices, certain stewardship-related practices, and perhaps this might have mitigated the impact on AMR. So we felt it was important to stratify by that variable. Quality was assessed using a risk of bias tool for prevalence studies. So our definition of AMR included any of the following pathogens, and this is based largely on the World Health Organization's priority pathogens list: MRSA, VRE, ESBL producers, CRE, carbapenem or multi-drug-resistant Pseudomonas, or carbapenem or multi-drug-resistant Acinetobacter. So we included 28 studies in this meta-analysis, or in the systematic review, but 23 of those had provided enough data for us to do a meta-analysis. Representation was fairly broad globally, so we had, but we did have more countries from high-income countries, more high-income countries participating, and that was most commonly United States and Italy. The data largely comes from hospitalized patients with some 17 general hospital setting and 5 in the ICU only. And data was largely from clinical specimens. There was a variable risk of bias with 18 studies classified as moderate and really only 5 studies rated as a low risk of bias. So something important to consider when looking at the quality of these studies. One of the challenges that we faced up against when trying to do a meta-analysis on these data was just the variability in how antimicrobial resistance can be measured. There were at least 4 different metrics that AMR was measured in these different studies. So sometimes incidence density, where they'll look at the cases of resistant infection per patient days, proportions like how many of Staph aureus are methicillin resistant, what's the cumulative incidence, like the resistant cases per admission or discharge, and then a slew of other different metrics. So that provided us some challenges to pool these data together, but we did our best by pooling all of the incidence rates into incidence rate ratios, all of the proportions into risk ratios. And this is what we found. So for gram-positive antimicrobial resistance, you look at the bottom of this forest plot, 0.99 is basically there's saying that there's no difference in antimicrobial resistance after or during the pandemic. But draw your attention to the I-squared, 91%. That means there's a lot of heterogeneity here. These studies are very variable, and so it's almost like we're not really comparing apples to apples. Similar situation when we look at the risk ratio for gram-positive AMR. We don't see a significant increase in AMR after the pandemic, but if you stratify by whether these studies reported having an enhanced infection prevention control or stewardship program versus not, this is where you see a bit of a divergence, where there appears to be a protective effect to having those programs in place. However, these changes or differences are not statistically significant, given the very broad, wide confidence intervals. Now, shifting gears to gram-negative AMR, you see an increase in antimicrobial resistance after the pandemic with gram-negative AMR, but this straddles 1, so not quite statistically significant, but that rate ratio is pretty high. Again, we see very high heterogeneity, and similar situation in risk ratio for gram-negative AMR, a trend towards increasing antimicrobial resistance. And when you stratify by whether they have a stewardship program or enhanced infection prevention and control, you do see a divergence in the outcome again, where there appears to be some sort of protective effect to having that stewardship program or infection prevention and control in place. So all this to say is that the data quality are kind of poor. I think we need better data. We need more sources of data. This is from published literature. It doesn't include the gray literature like what's coming out of the CDC. So I think that's an opportunity to improve upon this. But it does tell us the importance of keeping an eye on AMR as the pandemic has progressed and as we move out of the pandemic. This is the visual abstract for the paper, was published in CMI last year. I think a lot of these data actually align with what the CDC has reported, showing that for data that they do have in 2020 compared to 2019, a significant increase in antimicrobial resistance during that year, particularly in some of the organisms that I mentioned earlier, like carbapenem-resistant Acinetobacter, carbapenem-resistant Enterobacterales, and ESBLs. So how does this pan out in terms of thinking about future pandemics and just thinking about antimicrobial stewardship in general? Are there some learnings that we can apply? One of the things I think is particularly important is that we need to sustain our antimicrobial stewardship efforts even in times of public health emergencies. We did a survey across Ontario of stewards across about 100 different hospitals, and we found that there were, and probably many of you can attest to this, so many competing priorities for antimicrobial stewards, where they were getting involved in guidelines for therapeutics, addressing shortages, access issues, even getting involved in vaccinating patients. And this had an impact on some of the conventional stewardship activities that the programs were trying to do, like on the right-hand side, prescriber education, prospective audit and feedback. Those were either modified or suspended in many cases. So I think this really points out that it's important that we have adequate resourcing and capacity building in place to ensure that ASPs are adequately staffed when the pandemics hit. Many of us have prospective audit and feedback as bread and butter for our stewardship programs, and I thought this was a really nice study that reinforces how useful this approach can be. This was just published in the Lancet ID earlier this year. In Alberta, they did a cluster randomized controlled trial evaluating over 800 hospitalized patients with COVID-19 to either receive prospective audit and feedback or standard of care, and they found that prospective audit and feedback was associated with a 5% reduction in antibiotic use with no change in clinical status or adverse outcomes. And they looked at a non-inferiority design, so it was quite well designed in terms of what their threshold was. Vaccination is an antimicrobial stewardship initiative. We know this from previous pre-pandemic data. influenza vaccine is associated with reduced antibiotic prescribing, high certainty in adults and moderate certainty in children. Same thing with pneumococcal vaccination. And now we can add to that COVID-19 vaccination can also help to reduce antibiotic prescribing. So a few conclusions here. Antimicrobial use we know is generally high in COVID-19 patients, despite rates of co-infection and secondary infection being quite low outside of the ICU. Use is highly heterogeneous, but there's overuse in all settings. The impact of the pandemic on antibiotic use for non-COVID-19 indications has really depended on a variety of factors like the prevailing respiratory infection rates, access to care. But it appears that COVID-19 may have impacted and exacerbated AMR, particularly in hospital settings for gram-negative organisms and particularly in low resource settings. So I think these findings really reinforce the need for bolstered infection prevention and control, antimicrobial stewardship, and AMR surveillance, both in the context of COVID-19 and beyond. Just to finish with a couple of slides that show some of the learnings that I think we can apply to the future. This was a paper written by Debbie Goff in the Journal of American College of Clinical Pharmacy, talking about how we can be resilient in the face of a pandemic and learn from some of these difficult situations going forward. So at the top of this figure here, many of us have experienced a huge increase in our workload as we're infectious diseases experts, people coming to us from all different angles, asking all kinds of questions. Even though this is a lot of that was about COVID-19, it allows us to bring attention to the things that we care about as well, like antimicrobial stewardship, and highlight the importance of that. I'll move down a couple to the COVID-19 as a cause of pneumonia. I think the fact that COVID-19, people now know that COVID-19 can cause respiratory infections and pneumonia really highlights the fact that, community-acquired pneumonia can be caused by viruses. So I think this can help us to think about cases in which we could avoid antibiotic use in pneumonia, the use of molecular technology for targeted treatment. And then the last slide, I think I'll just highlight the comment about burnout, because we've been talking about this a little bit. Stewards were working across the board trying to address all of these challenges, some in very siloed fashions. I think here in Nebraska that may have been less of the case. But I think this provided us an opportunity to work together globally, to learn from each other, learn from their successes and failures, and move together forward in an interdisciplinary fashion. So with that, I'll close. I just wanted to thank the Toronto Antimicrobial Resistance Research Network for their support with these projects, as well as the members from the World Health Organization. And that's my email address if anybody has questions, and I'm also happy to answer if there is time.
Great talk. So we see the rebound. Things are going back where they were. Part of the antibiotic prescribing in the outpatient setting that decreased was because of less respiratory viral pathogens. Those are now back. How do we prevent going back to where we were? Because I think, as you said, we've learned some things with COVID that we don't have to treat viruses with antibiotics, but how do we not go back to the old habits that we used to have?
Yeah, I feel like that's like the million-dollar question. I know that some of the data that we have that shows us that how many of these infections were actually do not actually require antibiotics gives us a target that we can set when we're providing feedback to clinicians. I think that'll provide us some opportunity to say, okay, this is a percentage reduction that may be achievable, given that these infections were previously treated with antibiotics and they didn't need to be. I think also involving antimicrobial stewards in pandemic planning and public health emergency planning for the future, because I think we're going to see these spikes and valleys again, and we need better preparation, not only for the response, because we were quite reactive during COVID-19, but I think we're going to need to be proactive for future pandemics. But yeah, I'm happy to hear other ideas of how to keep that down, but it's a great question.
Hi, that's great talk. Thank you very much. And I was very kind of interested in the study that was done, I think, in Ontario, where they saw 22% increase in the nursing homes in the antibiotic stewardship, with the 13% in the community and 22% in the nursing home. Do you use the data at the public health level to do any interventions in the nursing home, or was there any? What was your strategy to get that word out in the nursing home, or even develop some interventions to that? Just kind of curious to know.
Yeah, that's a good question. These data were just recently published and recently kind of available to us. But I think that's something that we could incorporate in future feedback reports. We do what's called a My Practice LTC, which are feedback reports to about 400 long-term care physicians in Ontario. And they get a report every quarter in their email inbox that tells them how they're prescribing compared to their peers. It tells them about antibiotic initiation as well as antibiotic duration, and it gives them some recommendations for future practice. Had we known that this was going to be a huge issue during COVID, I think we could have incorporated a metric related to that as well, because those are all linkable data. So it's something to consider for future, and maybe even now, I think that could still continue to be an issue. So it's a potential metric we could be looking at considering.
Thank you very much. Thank you. That's actually amazing that they get quarterly reports.
Yeah, quarterly reports, it's voluntary. So right now, they don't have to sign up. And sometimes the issue is the people who sign up may not always be the ones you want to sign up. So that's something that we're looking to see if we can make it a little bit more mandatory.
Thank you very much.
Thank you.